I'm Dr. Laura Bachrach. I'm a professor of pediatrics in the area of endocrinology. And for the last 25 years or more, I've been really interested in the problem of pediatric bone health. To me, it makes very good sense that a pediatrician should care about bone health, because we know that the lifetime for bone health is established by the mid-20s. So we really want to establish a good foundation. In my own practice as an endocrinologist, I'm seeing an increasing number of children coming to me with a question of whether their bones are developing normally, whether bone fragility risks are increased. And even I'm even seeing children who actually have what we call pediatric osteoporosis at an early age. So what I'd really like to talk about for a few minutes is some of the controversies, some of the key areas where we have made progress, and some of the areas where we really need to do more research because the answers aren't there. So first of all, what do I mean by pediatric osteoporosis? In older people, one can diagnose osteoporosis on the basis of a bone density test or a DEXA scan. If the bone density is low enough on the DEXA, you earn yourself the diagnosis of osteoporosis if you're a postmenopausal woman. But in childhood, we know that the DEXA scan, even though we have normative data, there isn't sort of a cut point, a fracture threshold to allow us to make that diagnosis. So increasingly, we are focusing on fractures in children as sort of the gold standard for deciding when somebody does or doesn't have osteoporosis. So if you've had a low trauma fracture of the femur or the spine, that's enough to buy you the diagnosis. And having recurrent low trauma fractures may also give you that diagnosis, especially in combination with a low bone density. Some of the challenges and cases that I have run through at the Endocrine Society this year relate to special areas of children at high risk, and I'll give some examples. One case involves a ballet dancer who has been exercising intensively and has a stress fracture. Is that osteoporosis? How should we treat that? Second type of case would be a child with Duchenne muscular dystrophy who has a difficulty with mobilization, is not doing much weight-bearing physical activity, and therefore doesn't stimulate the bone to grow stronger. And then to compound things, has inflammation from the Duchenne muscular dystrophy and is on high-dose glucocorticoids. Is that a child who warrants investigation and treatment? So these are typical kinds of cases that might come to an endocrinologist or even to a general practitioner, a question of how many fractures are too many fractures. So my general advice is, in terms of evaluating a child like this or an adolescent, is to do a really comprehensive screen, go over nutrition, go over vitamin intake, go over physical activity, go over family history of recurrent or frequent fractures and low trauma fractures, and a history of hip fractures in the elderly. So a really good history and physical exam. In terms of laboratory investigation, we always look at things like the vitamin D level. We look often for celiac disease, which can cause bone fragility. We're concerned about possibility of sex steroid deficiency, and definitely sometimes go into genetic studies if we're concerned for osteogenesis imperfecta or other genetic defects associated with bone fragility. A controversial area is if and when to do a DEXA scan, and many families come in knowing about bone density testing. And this is a really challenging area because we can do a DEXA scan, but the results don't necessarily drive treatment because, as I say, the diagnosis of osteoporosis is really based upon a fracture history rather than bone density alone. So we can do a bone density test and sometimes see a low bone density for age, but not necessarily decide that's time to pull out a drug. But part of the evaluation process, in addition to potentially doing a bone density test, is to do a lateral spine x-ray. Now, the lateral spine x-ray looks everywhere from the upper to the lower spine. And if we see vertebral compression fractures in a child, that by itself is enough to give a child a diagnosis of osteoporosis, even if there's no DEXA done. So the lateral spine x-ray is definitely a reasonable evaluation tool to add to the toolkit. Talk a little bit about treatment. There is no FDA-approved drug for the treatment of osteoporosis. On a compassionate use basis, we are using bisphosphonates. This is the drug in the category of Fosamax, for example, that's used in adults. We rely in pediatrics on the intravenous forms of these drugs rather than the oral forms, due to studies that suggest that the IV form is more efficacious to prevent vertebral fractures, which is often what we're trying to treat. So there are two drugs out there. They're not FDA approved. One is called pamidronate, one's called zoledronic acid. And once again, they're not FDA approved, but we do use them as really the only drug in our toolkit that we have the most experience with in treating children with fragility fractures. Because they're not FDA approved, we want to be very judicious about when we pull out these drugs off the counter. And our criteria generally for treating is to treat or offer treatment to a child who's had a fragility fracture. By that, I mean a fracture, let's say of the long bones, let's say the femur, from standing height or less. So you walk across the living room rug and trip on the shag carpet and have a femur fracture. That would be a very concerning abnormal bone fragility fracture. And that's as opposed to a child who falls off the jungle gym and has a distal forearm fracture. Those are common childhood fractures. Again, the other fracture really pay attention to are vertebral compression fractures. And again, pretty much the only drugs we have in our toolkit are the bisphosphonates. And there are different protocols. People have different arguments about exactly what dose to use and for how long to treat. But there is that option for children who have diagnosis of osteoporosis based upon those fractures. Sometimes physicians, sometimes patients and providers are so worried about a child who's high risk, they want to use this as a primary prevention before first fracture occurs. So if you have a child with Duchenne muscular dystrophy and they're on high dose glucocorticoids and you sort of feel like, wow, I think there's a 20 to 40% chance they're going to have a fracture in their life. Can't we get started now? We aren't really ready yet to do primary prevention, that is, start this prophylactically before the first fracture occurs. But this is a rich area for investigation as to perhaps where we should do some studies and decide if we can identify well enough children at high risk to start a randomized controlled trial of using bisphosphonates for primary prevention. So to kind of wrap this up, this is a really important area for endocrinologists and general providers to know about, to think about bone fragility in childhood. If you hear a history of low trauma or recurrent fractures, think about the fact that a child actually could have enough in the way of risk factors early on in life to warrant drug therapy. To really understand the kind of pitfalls of just doing a DEXA scan if you have a low bone density for age, but no history of fractures. Do we do more harm than good by raising parental anxiety or anxiety on the part of the patient when we're not necessarily going to treat on that basis? These are all important areas for discussion. There are a lot of questions, a lot of opinions, but with attention to bone health, I think things can be looking up. Thank you so much.